Hello, dear friends. Here we are again with the interview series of Road to Venous Venice 2025. And let me say, wow, guys, today we are really lucky because we have, I have the pleasure of interview a really vascular surgeon rock star and estimate colleague and a really, really great human being, Dr. Ruben Rodriguez Carvajal. Welcome.
Thank you, Luca. It's my pleasure to be here with you, my friend. You know, it's for me always a pleasure to share some time with you and with this beautiful and lovely project that is Pain in Venice. So my pleasure to be here.
Thank you so much. Thank you also for the great work and the commitment that you are putting on the Pain in Venice Symposium. You really create a great program, but we will talk now in the interview about that. I would start by reading a short biography of you, but not a short biography, but just reading that you have trained in National International Center of Excellence. I read in Toledo Hospital Complex, in the Hospital Clinic of Barcelona, and also in the University Hospital of Zurich. So really great centers, and not just in Spain. So you moved for the excellence. So that's the point that I want to use for the first question. How important is to know different realities and different approaches to the vascular field? I mean, what's your opinion on that?
Well, I will say, Luca, that I think that it's not very important. I think that it is mandatory and absolutely essential for a complete formation for probably for any physician, but especially in vascular surgery. You know that there is a really complex field. There is a big field with a lot of pathology that we have to know how to deal with. And I think that I realized during my formation that the only way to see if what you are doing is the correct thing is to see how others are doing the same thing in the same way or in a different way. And there is always a good chance to learn. You know, I think we have to comply and we have to think that we are learning through all our professional life. I mean, we are teaching right now, but we are learning even, you know, from everyone. And when we share, when we make conference, when we participate in panels with discussions, for me, the full enrichment of all these events is what I learn more than when I teach, you know, because it's always something to learn. So for me to be outside of your comfort area, of your center, of your service, it's fundamental to understand that all that you do is not always the best thing to do. A concrete treatment or a therapy, and there is always different ways to think, different ways to move, different ways to offer solutions to your patients. And there is not a better way to do it than visit colleagues outside and to share with them how they daily do everything, you know, starting from basic protocols to ending of complex treatments in surgery or endovascular.
I totally agree with you. Well, we all know that you are basically one of the pioneers and leading expert of HIFU treatment, focus ultrasound treatment. And could you please tell us in few words what we talk about and how does it work?
Well, the HIFU therapy for varicose veins treatment, it's a concept that has absolutely made me be in love with from the beginning. I felt so attracted by the idea to treat a venous insufficiency from outside the body. And I think that the most important thing that this therapy adds to the actual armamentarium for varicose vein treatment is that we can absolutely take the patient outside of the theater, of the surgery room, and that was an idea for me that seduced me, fully seduced me, and I cannot hesitate to be involved in the therapy development and the therapy evolution. What I have to tell now, I think that the therapy is now in a in a really advanced position. I think that we have grown a lot in the last 3-4 years about applications, about protocols, about technology development too. And I think that we are now in position to treat practically 80 to 90% of cases with HIFU, regular cases that I regularly see in the office. And I truly believe that it's a future that will come. I hope that more soon than late for everyone in the world of phlebology. But for the conditions of the therapy regarding reimbursement and cost, probably we have to wait a little bit more. But I'm really a believer about its potential and its applicability in the next future.
Thank you. Thank you for this overview. I also would say that HIFU will be widely discussed at the next Vein in Venice. So I invite all the colleagues that are watching this interview to come and join us. But I also know that you perform thermal procedure, mechanical chemical ablation, sclerotherapy. So all the armamentarium, all the weapon that we have to treat venous insufficiency. So how is it important for a reference center to be able to offer all the range of treatment?
Well, I think that if we are talking of advanced phlebology and obviously, I think that each center has to focus how quality and how quantity of treatment they want to give to the patient. But if your aim is to treat or to offer treatment for all the spectrum of phlebology treatments, especially in superficial vein insufficiency, I think that it's mandatory to know at least 4 or 5 different treatments, just because the pathology itself it's occurring it. I mean, the variability that we have in venous disease, in superficial venous disease, it's perfectly look at it's quite big. So we have to study every patient individually, and we have to offer each patient the best solution that we have for them. For this, we have to know different therapies, different options, different approach, because there is a lot of variables that we have to take account in to decide what is better for each patient. But for me, it's mandatory to know, to be in knowledge about the different therapies, about the indications, especially which indication is differentially for each treatment. That's critical for me, and because you will always find a patient that will be benefit more than one therapy than the other. So yeah, I mean, after it's clear that you will offer, or you should offer to the patient the therapy which you feel more comfortable with. That's absolutely clear. But if you know different therapies and you have experience with different therapies, you will be able to treat more patients and to treat them in the more appropriate way. So that's my thinking about the different therapies in phlebology.
Thank you, thank you. So now we're going to talk about next Vein in Venice, because first of all, I want to thank you for your commitment and your great job in creating a wonderful program. Especially we talk about the session in dedicated to the treatment of pelvic venous disorder. in which you are the president and coordinator, and you really involve a lot of good colleagues with a great talk, and everyone will see. But could you give us a preview of the main topics that will be discussed?
Yeah, of course. Well, I have to say that it was not really hard work for me, Luca, because I'm really a lucky man. So I have a lot of friends through Europe from all these years. So it was just a phone call, just to propose them to come to Venice to have a good time, a good discussion, and a good a professional sharing. And they don't hesitate to come. And I'm really grateful to all of them. Names like Human Jalai, like 𝒁𝒐𝒂𝒅, like Professor Domenico Bacchelieri, really good friends that they will be in Venice discussing pelvic venous disorders. I think that pelvic venous disorders is a really challenging segment of phlebology. Probably is the more complex disease that we have to face every day, especially probably compression diseases. But in our space for pelvic venous disorders, we have two different parts. We will start talking about all related with pelvic congestion syndromes. So we will talk about the different therapies, the different options that we have to treat this disease, this venous insufficiency developed in the pelvic veins. So we will discuss about different techniques to treat gonadal incompetence with mechanical devices, with liquid devices, and we will discuss even the role of foam sclerotherapy in this area that seems to be a little bit annoying for many physicians. So for that, we'll have Professor 𝐕𝐞𝐢𝐧 with us to talking about the role of sclerotherapy at this level. And after we will discuss a little bit about acute thrombosis in iliac veins, in iliofemoral veins, and we will discuss about this new classification that we have for chronic occlusion venous disease in iliofemoral veins. And we will discuss too, we have the pleasure to have with us Dr. Alejandro Rodríguez Morata too, that will discuss with Professor Domenico Bacchelieri about endovascular or surgical treatment for compression syndromes in iliopelvic venous disease. So I think that it's a really complex and really complete program. I think that assistants will really enjoy the discussion because I reserve a little bit of space for discussion. For me, it's really important, the discussion time. So I will invite everyone to come to this session. They're going to be in Saturday morning, and I think that we will enjoy a really great time together.
Thank you, Ruben. But I want to say a little bit on this topic again, by saying that I have read your paper. Thank you for sending me. It was really a nice paper, outstanding work that you did on the treatment of venous origin chronic pelvic pain by embolizing with detachable fibers coils, 255 patients. And what impressed me about your work is that you treated basically all these patients by embolizing the distal part and the main trunk of the gonadal veins, but without embolizing the distal varicose veins and without using sclerotherapy and glue. So that's my question. It's a choice that comes from what? It's something that comes from your past, or can you tell me that?
Well, I have to tell you that there is always an accumulation of variables and conditions that make you take one way or another. No, this is a really I'm really proud about this paper because it's 10 years work that we have developed in our unit here in EV Vascular in our institute. And what we start to do from the beginning was basically within the idea of removing the reflux from varicose veins. So the idea from the beginning was to see if with these detachable coils that seems to be more occlusive and softer than the traditional steel coils, no, that was used for another territories. If we were able to remove the symptoms, just treating the main trunk as we can do with the endolaser or with the endothermal ablation in some cases, that we have a good perforator drainage, for example, or we have not too much varicose veins distally. So thinking in the sense that we have not an aesthetic obligation in these patients, because really pelvic varicose veins are not visual from outside in general. Exceptionally, we have some vulvar veins that could be treated with foam from the outside. But in the majority part of these cases, we have not this necessity to be aesthetically correct or aesthetically accurate, when we do the treatment. So we start to do this technique, and we realized that we got success reducing clinical symptoms. Patients answering to the treatment was really good, was really positive, and we just try to adjust our coil delivering just to the necessity that we thought that the patient have, and especially because the embolization of varicocele distally in the pelvic LUCA, it's a situation that could imply in the long term some decubitus problem, especially with the tubaric tubes, with the ovarium, and with the uterus. So we realize that if it is not necessary, or if it was not necessary, why we have to do it? And what it is implying in the discussion of the paper, that I'm sure that you read it, we don't exactly know the quantity of sclerotherapy that we have to use for occluding or not occluding this quantity of varicose veins. I mean, we have not the way to measure this volume, because we have not an occlusion process that could retain the volume inside the varicose veins and make a prediction of how many foam we have to use, and more or less the same with onyx or with all the glues, with the condition that we have to leave inside the vein a chemical substance that we don't know how we will react, in time, especially thinking that we are treating young women, and they have a lot of years to live and a lot of years to get maybe more pregnancies, maybe more surgeries in the future for another reasons regarding urinary system, regarding bowels. So all these concerns make us to define this protocol, and well, I think that we can demonstrate with this paper that the protocol works, the treatment works, and it is not necessary to leave just a soft coiling inside the vein to leave it well occluded and to resolve the pelvic insufficiency. So that was the aim to expose it, and that was the reason, because we do the job, and we finally reached to write this big paper that was a really big job for us.
Yeah, I will stay again on your paper. First of all, saying that what you say is totally reasonable, and I think it is something that we should take care about the results that we look for. In this case, was the pain, and probably, as I read in your paper, you had a great reduction in pelvic pain. So that's the point. We are looking to improve the symptoms, to improve quality of life of this patient, and so probably not to be so aggressive would be a good choice. And then, of course, if necessary, we can do a second procedure, or we can treat from outside, as you said, the escaping point. So totally agree. And I will stay on your paper again, because I think it's really interesting, the results that you have. Also, I would like to ask you for an advice for colleagues that start this kind of treatment, type of treatment, sorry. And you have experience in 5 patients and a small amount of bleeding. When you treat, basically when you try to catheterize the right gonadal vein, especially when the arise of this vein were from the cava between 10 to 12 o'clock. So after your experience on that, do you have any practical advice to reduce this kind of risk?
Well, my advice, first of all, is to, in the pre-op image, get well localized where the right gonadal vein is coming from, because usually it's difficult to reach this origin, because as the dilatation of the vein is coming from distal to proximal, what we sometimes have is that maybe we have a 9-10 millimeters right gonadal vein in the top of the pelvis, but we are just 3-4 millimeters in the origin, in the vena cava. So that makes the catheterization a little bit more tricky, and it's really important to localize, especially looking, the clockwise, where exactly the origin of the right gonadal vein is, because that helps you a lot positioning your X-rays, and after position your catheter for the canalization. When what sometimes happen is that in the origin of the gonadal vein, we have some collaterals connecting with even the right renal vein, or even with lumbar veins. And sometimes if you put your glide wire inside, or your catheter inside, you can break it, you can make provoke a little bleeding. But as I always do to my colleagues, to my surgeons team, is that we don't have to be worried too much with these bleedings, because we are talking about non-open patients. I think that of course vein bleedings, we know that in open surgery vein bleedings are terrible, so we have to try to avoid absolutely vein bleedings. And when we have the patient close, when we are walking from endovascular side, and we have all the connection tissue around the vein, and this bleeding usually, if the patient is not decoagulated, because we perform all these procedures without heparin. We don't give patients never heparin for these procedures. You don't have to be afraid about these little bleedings or these little ruptures of these little veins, because usually it's something that it's self-controlled, and it stops just alone. That you have to be back again and try to go inside the right channel or the main trunk of the gonadal vein. So planify the treatment well with the previous image. We common use MRI for identify gonadal veins. We have a protocol with our center that we hope to publish soon, with a non-contrast MRI, with an axial sequential that it's more than enough to detect and to evaluate gonadal vein diameters, position, connection with varicoceles in the pelvis, and even suspicion of compression syndromes at the left renal or left common iliac vein. So preparation is always fundamental, because that makes the procedure safer, faster, and more effective. So that's what I have to say about the gonadal right vein. But it is true that it's for me, it's the more tricky point of gonadal embolization. It's the catheterization of the right gonadal vein, because sometimes it's a failure, a failure point in this kind of procedures.
Yeah, probably also for this reason you always try to go from the, talking about the access, not from the common femoral vein, but through the
yeah. Yeah, absolutely. That's a thing that we learned from the beginning, because it's absolutely amazing how you can access both gonadal veins, even the hypogastric area, with 4 French 125 centimeters catheter, just from an antebrachial vein. My favorite is the basilic antebrachial vein. This is the most easy one, because in the arm the curve is really lazy, and you have no problems to cross through your catheters, even if you have to change for a pigtail to make a three-dimensional venogram of the suspicion of renal or iliac compression. You can do it easily, and you can access both sides without any problems, because usually, I told you, usually the origin of the right gonadal vein, it's a little bit, is between 20 and 45 degrees from the vena cava, and I mean, from up with an MPA catheter, it's quite easy to go in if it is not quite angulated. So yeah, it's a simple access. Finally, it's like like a branula in the arm. I mean, the patient is feeling that as he has a a vein access in the arm, and it's really more comfortable that to go through femoral. Absolutely.
Yeah. Also for the procedure that you can do like without putting in a bed your patient after the procedure. It's a kind of easy also for that. So to be practical, when a patient come to your office with atypical varicose veins, what's your protocol? How do you manage the case?
Well, I think that the first step and the first basic movement that we have to do is to have a good anamnesis directed to pelvic symptoms. Okay, because usually the patients are coming annoying for the varicose veins. Usually, in the external part of the hips, even in the gluteal area. This is the typical area that we have, overpressure coming from the pelvic area, or especially in cases of patients that has been intervened previously from varicose veins in the legs for a recurrency. So that almost 30% of patients are coming from a leaking point from the pelvis area. So it's mandatory, first of all, a good anamnesis to ask for symptoms in the pelvic area that usually appears, especially related with the period, especially in women related with the period. They have more pains. They experimented more pains in the legs during the period. This heaviness, this tightness is absolutely accentuated during the women period time. And usually they have increase in the days of periods and in the pain of periods, and even in the bleeding, in the amount of bleeding during the period. So for me, it's mandatory these first questions, just to, we take for you 2-3 minutes to know if you could be facing a recurrency or a situation of pelvic venous insufficiency. Afterwards, we always perform an ultrasound, in the clinic, just to check, obviously, reflux in the legs. We find any point of reflux coming from the gluteal area, and we perform a transabdominal duplex just to check. Sometimes it's easy if the patient has not eaten for a few hours and it is not too fat, so we can identify easily the gonadal veins, over the fascia of the psoas muscle, and you can even take measures, see if there is any dilatation, or even with a Valsalva maneuvers, you can identify if there is any kind of reflux in these veins. And to confirm the suspicion, we always ask for an MRI, as I told you before, and we make the patient to come back with the results. And with all this, we planify the treatment with them. Usually, always we ask for the patients to have previously a gynecological evaluation with a transvaginal duplex. That it is always helping to identify varicoceles or dilated varicose veins in the pelvis. And usually the patient, the majority of patients, the big amount of patients are coming with evaluation done because they are almost referred by our colleagues gynecologists. But if not, we ask for it too, and then we planify the treatment if we find that we have this gonadal veins dilated in the MRI.
Yeah, I think that multidisciplinary approach is always the best thing, also to exclude other cause of pelvic pain. So I think it's totally right. So my last question, then you're a free guy. It's the question that I like the most because it's a question that is dedicated for young colleagues, and the question is, would you recommend to a young vascular surgeon to approach the venous field?
Well, I will recommend them to approach it with enthusiasm, because it's a field that usually it's a little bit dismissed during our vascular surgery formation. That it's true. I mean, we have to say it. The vein field, the phlebology field is a little bit, for me, infra-evaluate during the formation of vascular surgery. I mean, it's true that we are not maybe saving lives like with arterial or saving limbs, but the reality after is that you will have to face this like the 70% of the patients that are sitting in front of you with a vein problem. So I will encourage them to get and to accomplish a good formation in phlebology, a good formation in venous disease, in venous field, because they will help them to help a lot of people, to improve the quality of life of a lot of people, and to develop their specialty in a complete way. I think it's mandatory to understand, and that's what I think that I realized during my career, that we don't have to be super vascular surgeons. I mean, sometimes the idea for young people is, no, I have to do aorta, I have to do carotids, I have to do distal bypasses, I have to do arterial. Yes, you can do it. I mean, you will learn it and you can do it, but you have not to dismiss the biggest part of our specialty, of our pathology, that it is venous disease. Because it's a really important field, and it's a field that we should get formation, we should get experience, and we need to know how to treat and how to resolve our patients.
Yeah, thank you so much. And I would close by saying to this young colleague to pay, probably it is right to pay a visit to your clinic and learn from Rockstar. Thank you so much.
You're welcome.
And for your time. And well, it will be really a pleasure to have you in Venice, and we will go for a dinner together before in Venice.
Again, the pleasure is mine, Luca. I mean, I invite you and all the colleagues that want to come to eBay Marbella to know about all that we do here. And I'm happy to share our experience, because it's an essential part of our job, in my opinion. And I will be very happy to see you and all our colleagues in Venice. Obviously, I invite everyone. Please, you cannot dismiss this opportunity to share and to learn about really top colleagues, top physicians from venous disease in Venice 2025. So please come and join us.
Thank you so much.
You're welcome.